Prasad to take over.
Sir, I would like to invite Dr. Sarath Chandra.
Yeah.
He'll be presenting on protocol on OT during COVID pandemic. Very interesting topic. Dr. Sarath Chandra.
So good afternoon, everybody. Are you able to hear me and also see my slides?
Yeah.
Okay. So thank you very much. At the outset, I would like to thank the organizing committee, Dr. Ravi as well as Dr. Venkatraju, for having given me this opportunity to speak on this very important topic, because after the earlier speaker, we come to the other front line of management or front line of this war against COVID, which happens to the operating rooms. And unless we create some kind of definite protocols, there will always be chances of outbreak of infections and exposing our healthcare workers as well as doctors to this pandemic. So obviously we have been talking a lot about PPE, and most of us are used wearing PPEs, but I thought I should bring this up a little bit. So obviously when we think of the protective gear, it consists of, if you look broadly, what is protective equipment? It consists of garments to place to protect the healthcare workers or any other persons to get infected. And generally by this we mean that it includes gloves, mask and gown. So if it is a blood or airborne high infections, obviously we need some kind of face protections, goggles, a mask and shields and so on. So now obviously, we do not have unlimited amount of PP, and that is actually placing a huge challenge on our health infrastructure. And that's the reason we need to optimize the use of PP. So obviously, any hospital which is managing COVID or COVID free centers has to develop techniques by which the usage of PPs could be minimized. So one of the primary areas is, of course, optimization of telemedicine, and that is what we are also currently doing, where most of the conferences, patient consultations, as well as most of the meetings and even online rounds and academics have become online. Similarly, it's very important that whenever we have a physical OPD or where we meet the patients, we create physical barriers, so that which can again minimize the use of PPE. And it's very important to restrict the number of healthcare workers entering into the rooms. And it's also important for number of people entering into the OT. So obviously the operating rooms cannot be something which was earlier, where a lot of people, students could enter and they could see there was a teaching session. So obviously all that has to be minimized. And the way the teaching can be optimized is you could have CCTVs or you could have videos and they could all watch from a separate online modules. Now that is why it's very important to optimize it. Now, how are PPEs tested? Now, this is very interesting. Obviously, there are every protective material cannot be PP. So if somebody manufactures a plastic, we cannot say that, oh, okay, this is a PP, this can. So there are certain criteria and there are certain tests. So every PP which is approved for use to protect against COVID have to undergo through all these tests, and they include synthetic blood penetration test, moisture vapor transmission test, weight test. There are certain companies, they say that we have 100 GSM absolutely impenetrable. But if you try to wear those PPs, they're so heavy and so difficult that you could not even wear these PPs for a few minutes. Similarly, the fabric strength is also very important. The seam test again, whenever we are suturing the ends of the PPs, we have to ensure that the sutures are worn properly, because if they break down again, there could be breakdown of the barrier. So basically, when we speak about PP, we speak about three things, and this I'm sure most of you will not know about this already. But again, I'm speaking this for the sake of students or for the people who may not be knowing this completely. So overall, we have PPs are measured in terms of GSM, which includes grams per square meter. So the kind of PP which is recommended for treating COVID patients is 100 plus grams per square meters. It should be at least 100 plus above. And this is a kind of suit which we recommend while the person is treating COVID patients. And in the front, we have a zip and there is a sticker. So you peel off a paper and it sticks over there so that it completely becomes airtight. So the basic kit is obviously, which is 45 GSM, and then, you have a medium kit, which is around 50 to 70 GSM. And then you have this kind of a PPE kit, which has to be used while treating patients and also by healthcare workers who are exposed to the highest form of risk. Now, the question is, why do we need a PPE if it is an airborne disorder? So this is a question which always comes, and many of my residents have been asking this. The most important reason why we need a PPE kit is to prevent the spill of bacteria on our OT clothing or on our skins. So it is most important to prevent the spill and reduce a cumulative viral load. So if the healthcare workers are working over a period of time, if they do not wear proper PPE kits, then the risk of spillage of bacteria on their inside clothes or on their skin will be high, and subsequently they will have a higher risk of catching infection. So who can wear the level 3 PPEs? So obviously in surgeons in OT, they have to wear a level 3, because despite the number of tests you do, there could always be false negative or false, we may not be completely sure. At the same time, we cannot be assured about the health of the other healthcare workers. So if you're working in a closed room, and especially if you're working for a long period of time doing surgeries, which may last 4, 6, 7, 8 hours, it's important to have a complete barrier. So all the surgeons in our OT, they wear a full PPE, but these PPEs are quite lightweight, even though they are completely impermeable. Now, level 2 is to be used by staff, cleaners, healthcare workers, drivers. They provide a less degree of protection. So obviously, they'll look like a gown below. So there could be some contamination of infection from below. But again, if you're not there in a high risk area, you could wear a level 2. And finally, the level 1 or the basic kit is to be worn whenever a person sees in OPD any patients, or in the waiting room, or in the administrative area. As of now, if the administrative area is completely different, one can just manage by wearing masks, as well as maintaining proper social distancing and hand hygiene. But whenever there is a public interface with the patients, it is advisable that you should at least wear a basic kit. Now, this question has always come on to me, that how much of respiratory protection is actually enough for COVID infections? Because when we speak of N95, we say that it has only 95% filtering capacity. And if a person goes on wearing this in a COVID environment, what is the risk of this healthcare worker catching COVID? So one can see that there are different type of masks. In the low end, we have the N95 masks, which is used by 95% of the people. In the mid end, we have something called as a P100 filters with 3M goggles, which is again available. The cost is not much. It's around 1500 to 3000. It could be used whenever one is operating upon COVID positive patients, because there the risk of catching infection is high. And in the highest end, you have this complete full face airtight security with a 3M P100 filter, and there is a breathing pump attached. Now these are obviously very expensive. They cost somewhere between 8 to 10,000 rupees. But again, they're recommended if you're working with COVID patients, or if you're working for a long duration of time. So as of India, I think only a few surgeons or few hospitals have invested into this. And most of us, we either wear the regular COVID kits. And I think about 20-30% of the surgeons I know, they wear this P100 filters. And I'll show you about this. So obviously, it's very important for us to innovate when we are dealing with COVID patients. So it's very important to wear triple gloves. I always recommend triple gloves. Then wearing double shoe covers. Now it's very important to seal the neck. I would recommend all the surgeons to invest into a good airtight goggles. So you can get commercially, you can get these airtight goggles available. They're not very expensive, 700 to 800. But choose the type of goggles which will have this kind of a rubber seal on protection, which will completely seal off the eyes. And this is much more better than wearing the face shields, because face shields, you have the sides open. So if you're working in a high risk COVID environment for a longer period of time, you will have some risk of catching infection. You should use the micropore to seal off all the exposed points. So if you go to the trauma center, which is now currently the COVID center at the All India Institute, you'll find these huge waiting rooms, where you have large television sets showing how to don and how to doff. And then people are wearing the COVID kits. So once they wear, there are dedicated nurses who will take this micropore and they will ensure that everything is sealed off. And once that is sealed off, you are asked to stretch your hands, raise your hands, and move your legs to ensure that every point is sealed. And then you enter into the COVID environment. So this is the kind of precaution which is required if people are working in working with patients who are having active COVID infections. It's very important to follow the correct sequence of donning and doffing. Most of our healthcare workers, they have got infected whenever they do not follow the proper sequence of doffing. And doffing is very, very important. I have seen so many healthcare workers, they don't follow it properly. So it has to be in a very, very slow manner. It has to be peeled off. And I will show you a video shortly. So this is the donning and doffing sequence, and we will reach to that. Now, what are the protocol for intubation of the patients? So this is a protocol we follow. I'm sure this is available in most of the hospitals. You have this perspex blob box which is kept over the head of the patient, and there are holes here through which the anesthetist can enter his or her hands. And you can see all of them, they have to wear airtight goggles, N94 masks, and on that they will put on the surgical masks. The reason we need to wear double masks in the OT is to prevent the spill of bacteria onto the N95 mask. So this is just to reduce the spill. That is the reason we use double masks. So obviously there is an entry and exit, only one-way system. So whenever we speak about OTs, there should be only one door to enter and one door to exit. Intubation with an aerosol box. And once intubation is over, we wait for about 20 minutes before we start cleaning and draping for the surgical procedure. So right now all the OTs have a negative airflow pressure. So which means negative means that the air from the OT is sucked from outside and it is taken off actively into the air conditioning system. So usually OTs have positive airflow, which is not recommended because this air can move out of the OT. So after waiting for 20 minutes, we start scrubbing and draping. So to the extent possible, we avoid any kind of aerosol generating procedures. So we have stopped doing all our trans-oral or even trans-nasal endoscopic procedures. For pituitaries, I prefer to do a eyebrow incision or other minimally invasive cranial approaches. Now it's also important to change gloves after craniotomy. So there are some companies which have come up with protective umbrellas which you can cover over the operative site, but it's not required because there is no transmission of the infection through the blood. It is an airborne infection. Only patients who have severe COVID can sometimes transmit through blood streams, but otherwise once the whole surgical area is draped and only the surgical area is exposed, one can remove the goggles and start working on the microscope. So goggles are required till the draping is over, and then once the microscope comes in, the surgeon can remove the goggles. Now the OT dress which we have is, I will just show you a short video on to how to show it. Now we've also distributed this 3M half face masks with P100 filters, and I will strongly suggest that every physician or surgeon should have this P100 filters. They are available for about, I think, just 2,000 rupees. So you have this P100 filters, they could be kept in a polythene bag and they could be kept for 24 hours and then again reused because you cannot sterilize them. If you have an ultraviolet sanitizing box, you can use the P100 filters from sterilizing it. So this is how we pack our P100 filters and keep them. So the filters are kept separately, the half face mask is kept separately, and all of them is packed together in a this kind of a sealing plastic box. So you can see that that is a P100 filter which is kept separately. And then this is the goggles which is again kept separately in a plastic shield. And you can see that this goggles has this rubber around it. You can keep a cloth also to clean it. And then finally we have this half face mask. Now I don't say that you use it for every case, it's not required. Only when you feel that you are being exposed to a high risk environment, that is when you need to reuse this, and it should be always available in your bag or a kit. For instance, you are asked to go to the emergency, or you're asked to go into a closed area where you think the risk could be high. That is where you need to use this kind of sealant. Now in Neurology India, we published this donning and doffing procedure, and I will briefly run this video, and I will also request all of you to see this. So the donning area, we have converted the area outside the OT into the donning area, and these are the things what we have for donning. So you can see that we have N94 mask, we have gloves, and donning is literally straightforward. So obviously you have to do a hand hygiene, and the surgeon wears the shoe covers first, and we put on the shoe covers over the gum boots, and then he wears the health head cap. I'm sorry. Yeah. And then he wears the 3-ply mask over the N95 mask along with the head cap. And then one wears a level 2 or a level 3 coverall on that. So this is a thin level 3 coverall. You can zip it, and you have to strip off the paper so that it sticks over it. And then we push up the hands, and over here we are wearing double shoe covers. So nowadays we just use a single shoe cover over the gum boots. That is enough. There is no need to wear double shoe covers. And then now we scrub. After scrubbing, we put on the OT gown on top of the and then we put on the sterile gloves, and then we put on the cap. Now this is, and from there we have, you can see we have put arrow marks into the OT. So the person enters into the OT, and once he enters into the OT, the door is closed and he doesn't come out. And then when he comes out, there is a separate doffing area, and you can see the procedure. So the first thing is removal of the headgear, which is the most contaminated, which is the face shield. And then between every procedure, one has to sanitize the hands. I'm sorry, I don't know why it is. And then you can see that the gown is removed in a slow writhing movements, so that you are slowly folding the gown completely and then throwing it. One should not do rapid movements, because if one performs rapid jerky movements, that can lead to again dissipation of the bacterial material. And then you wear a fresh pair of gloves, and then remove the shoe covers, and then clean the boots with sodium hypochlorite or with absolute alcohol or with 70% ethyl alcohol. And then you remove the coverall, and here you need the help of an assistant to help you to remove the coverall. Then you have to sit on the clean chair. So you have to keep one clean chair as well as one dirty chair. And you can see when you remove it, you have to slowly invert it and convert it into a ball. So the technique of removing or doffing is very important. No jerky movements. Remove them slowly, invert it and convert it into a ball, and then dispose of, so that the infected portion is inside, and you invert the cover completely. And then you remove the inner shoe covers, and then you finally clean your hands, remove your masks at the end, and finally remove the gloves. Come out, wear a fresh mask and a glove. Clean the box where you have kept the, wash your goggles yourself, mop it dry with a towel, keep it in a glove box, and finally keep, this is what we do, keep the goggles as well as the plastic box in an ultraviolet cabinet, and sanitize it for a period of 8 minutes, so that the goggle is completely sanitized, and you keep it in a separate plastic packet, and you can take it home with you, because it's an expensive thing and you need to keep your own goggles with you. So you can see the details in Neurology India. It's a nice video. And you can see that when we started, we had to convert one of the ORs into a doffing area, and we had to streamline the traffic by placing this kind of stickers on the floor. And you can see this is a one-way traffic. So when a person enters into the OT, performs a surgery, goes from here, comes into the doffing area. So he first comes to the donning area, enters the OT, goes through an exclusive corridor into the doffing area, comes out, and then goes to the elevator lobby, has a bath, and then exits the OT. So it's important to maintain this kind of protocols. Otherwise, there is a risk of the healthcare workers getting infected over a period of time. Now we have to also do streamlining of surgeries. I will not speak about it because we are almost 8-9 months down into the pandemic. But I will advise you, all of you, to read this very popular article in Neurology India, which has more than 100 citations as of now, which is a consensus statement from all the major institutes of the country. Now it's important to optimize the OT workflow. So every day morning there is it's important to do a team huddle. But team huddle, I don't mean that physically everybody gets together or touches each other, but to plan out on how the OT is to be streamlined. It is very important to create a negative pressure environment, and it is important to ensure that every OT has a separate air duct flow. So one has to speak to the engineers to ensure that there's a separate air duct flow. If one can afford a powered air purifying respirator, that is excellent, but it is quite expensive. So failing short of this, using a N95 masks with a double surgical mask is good enough, along with goggles. Now, after surgery, it's very important to dispose of the single-use equipment. All the instruments should be sent for decontamination and sterile reprocessing. Surfaces of all medical devices should be cleaned with ammonium chloride before they are sterilized. The OT then should be cleaned with sodium hypochlorite, and then followed by ultraviolet radiation. All staff should then shower and change into a clean set of scrubs. It is important to avoid taking laptops or sensitive electronic equipment into OT, because if you do, there could be areas into which the infection or contamination may enter and you may not be able to clean it. And if you do have to take, then you have to ensure that you cover it with plastic sheets. It's important to record the names of all participating staff so that it will facilitate contact tracing, because if there is some kind of infection, it's important to have a contact tracing. Now, ultraviolet sterilization has come up in a big way for sanitization because it's very effective to kill the COVID viruses. And if you look at the mechanism of ultraviolet, the way ultraviolet UV light kills COVID viruses, it penetrates the virus shell and reaches the DNA strand, and it is absorbed by the nucleotides of the virus DNA, and it causes a photochemical fusion of two adjacent nucleotides, and that is why it permanently changes the structure of the virus RNA, making it incapable of infecting any living cell. A UV wavelength of 254 is most effective, but however, one has to understand that it has only 0.4 millimeters of penetration, which means that it is capable of sanitizing the areas or sterilizing the areas which are completely exposed. Now, commercially, you are now getting a lot of nice products, like you have this oven which is called actually as Corona oven, and you have many other products where you can use it to sanitize your personal items. And I will strongly recommend that every OT or ward should have one of this. And more recently have come up, this is a little bit more expensive, where you can sanitize the full PPEs by hanging them on clothes hangers, which I think is an interesting option for us to explore in order to optimize the use of PPEs. So in our ward, we have installed one of these wardrobes. So the resident, if he has to go to emergency, he gets only 1 or 2 PPEs for the whole night. So every time he goes to emergency, he or she hangs this in the UV wardrobe and then could reuse it after it is sanitized 9 or 10 minutes later. The scientific validity, of course, has to be proven, but there is enough data to show that UV light is quite effective, especially on the surface of any material. So if you see the pros of UV sterilization, it's convenient to use, no chemicals are needed, therefore you don't leave any chemical residue behind. It is also able to kill all kinds of microorganisms, including bacteria, fungi, viruses, spores, and etc. But however, direct exposure is dangerous for human beings. And the most important thing is it works only in the light path. So all the items have to be kept exposed. You cannot pile up the equipment on one on top of another, because then the UV light is not going to be effective. So they have to be kept separately. And it is also important to understand that in UV sterilization, distance matters. So it is 100% effective at the source. But the moment you go to 10 feet, the effectiveness falls to only 1%. That is why nowadays you have this commercially available equipment which is called as UV plus ozone, which kind of comes up and you can use it very effectively. So both the ozone gas as well as the UV is capable of sterilizing the entire OT after doing a conventional sterilization. Now briefly about masks. We have all spoken about masks. I will not speak more about them. But if you look at the efficacy of masks, you have from N95 till PPP, FFP3 masks, which are said to be the most effective. Now all of us know that we should not use masks with valves because it doesn't protect the people around. And it is very important for us to optimize the use of masks. So one can keep the masks in a dry paper envelope. So if you see this short video which has been published by AIMS, so this young doctor explains on how you can optimize the masks. So after the use every day, you keep every mask into one paper envelope, and you keep it in a dry place and you can use other one. So this way you can use the mask 5 times. Each mask can be used for 5 times. So if you have 5 masks and each being used for 5 times, so every 1 month you can use about just 5 masks, and that is how you can recycle the masks. Now, it's very important. I know sometimes we feel a bit awkward about it, because unless we see the patients personally or unless we have a combined rounds, we don't feel satisfied. But however, the situation demands it. So it's very important for us to have an inter as well as intra team splits. For instance, in our department, the physical rounding is done only by one faculty, by the ward on call resident as well as the ICU on call resident, and we have an online combined rounds at a specific time in which all the faculty and all the residents join, and we are able to interact and we are able to take decisions for all the patients. So it is important to create this kind of intra team splits. One should not unnecessarily try to spoil the discipline by again engaging into multiple rounds and then saying, okay, I will now do the round, I will again come for evening, because the residents at the end of the day, they are at the receiving end. So the consultant or the senior faculty has to take a lead, and he has to set up some parameters for disciplining during the round. So they have to restrict themselves from seeing the patients multiple times, and only the faculty on call should see. If the senior faculty wants to see, they should, or he or she should do rounds at a different point of time. Now, obviously, we are not doing electives, even though recently we have started doing electives, because we know that if the patient is in the incubation period and develops COVID, the morbidity could be high, morbidity and mortality could be high. But we have to understand that this may be persisting for another 1 year, we don't know. And it is very important for us to create the protocols as early as possible, as rigidly as possible. And we should try to see that our academic work, our research work, as well as clinical and service does not suffer. So these are the general lifestyles. I will not speak about it because most of you know, but you could read the article in Neurology India to see what are do's and don'ts. And often, when we meet people, we are taken into a false sense of, I shall say, false sense of security. That when we meet people, will say, oh, it doesn't matter, let's have a cup of tea. We have not had a cup of tea. So this kind of meetings should be restricted. Similarly, we have found that one of the largest source of infection in AIMS were when nurses used to take all precautions when they were in ward. But then they had this tradition of getting into this small room, and they will take off the masks and have lunch together, and they will share their lunch. And that, they really enjoy doing that. And that is where most of the nursing staff are getting infected. So these are the areas where one has to seriously explore, and they have to follow strictly that this kind of physical interaction should not be done. And of course, there are a lot of other things where we need to do a significant changes in lifestyle. For instance, I have been going to hospital only in my OT scrubs for the past 8 months or so. So I'm not gone in civics for such a long time. Similarly, when you get to home, again, it is very important to optimize the protocol at home. One should inform, and all these protocols, I think most of you know how is to be done. Bottom line is, war against COVID is still on. So end of lockdown obviously doesn't mean end of COVID. And we are also understanding that the individual response to COVID is unpredictable. So this is my MBBS batchmate who is now on ventilator. Young person, I would suggest, not saying maybe I'm just 50 years. So he's around 52, 53. And right now he's on ventilator and half of the lung is gone. Whereas the surprising part is his children have got over COVID, his wife has got over COVID, his parents have got over COVID. But unfortunately, he's on ventilator and is fighting for his life. It's also important to understand that yes, at some point the COVID fatigue does set in. We start questioning how long this is going to continue, what shall we do? And then you get this false sense of security from other people saying, oh, it doesn't matter, I've got COVID, I got over it, was absolutely no problem. So we have to understand that this could be unpredictable. We still have to continue taking adequate precautions. Students' academics and trainings is something which is definitely a challenge, because especially for surgical areas, the residents do not see so many surgeries. Definitely the training may suffer. So it's important to run the elective OTs, even though you run it at 60% strength or 70% strength. So we were running at about 30% strength. Now from January 1st, we are going to run it at 60% strength, and we are slowly going to increase the strength with all precautions in place. Now, finally, before I end my lecture, I will speak a few words about air conditioning, because I know that a lot of people, how much time do I have before can anybody tell me how much time I have? I didn't note my time before I started my lecture.
Dr. Sarath, I think a few minutes.
Few minutes. Okay, so I will wind it up in about 3 minutes. Thank you for informing. So if you look at air conditioning, you have this mechanical and in-demand air conditioning system. So is it safe for us to have air conditioning? It is safe provided it is on 100% outdoor air and there is no recirculation and the damper valves are closed. Humidity doesn't have any effect on COVID virus. So it is important for us to have prevent us to have any kind of recirculated airs. And there is something called as a damper valve, and this should be closed so that it runs on 100% fresh airs. And it is important for every hospital administrator to speak to the engineers to ensure that the central air conditioners are on the 100% fresh air recirculation mode. I would discourage split air conditioners, especially in public area. You can use split air conditioners in your personal chambers or rooms. Apart from that, it's important to optimize the toilets. One should flush toilets with the lid closed. There should be good amount of exhaust fans in the toilets. Now there are areas where one cannot put the air conditioners into a recirculation or fresh recirculation mode. For instance, the air conditioner in a seminar room, moment we put it on a fresh air circulation, the cooling wasn't effective at all. So what we did is we installed small exhaust fans onto the glass windows, and this could kind of provide some kind of recirculation within the room. So this kind of innovation is very much required. So air conditioning is safe provided it's central, kept at high circulation with outside air dampers closed. Do not change the humidifier settings. It should be run 24 hours or at least 2 to 3 hours before and starting off of the regular hours. In case of hospitals, it should be run 24 hours. Do not use the individual window or split air conditioners, especially in patient areas. There is no use cleaning the air ducts. So please do not end up cleaning the air ducts because it is highly risky. There is no point cleaning them. And filters should be cleaned as usual.
Sorry, sir, we are running behind the schedule, sir.
Okay. So I will end my talk stating, this article which has been published in Neurology India, where it says about a King Solomon's ring, who says there was something engraved on this ring, and it was contributed by Dr. Timmappa Hegde. And when he died, when people read, it said, "This too shall pass." So it brings happiness for the sad and sadness to the happy people. So thank you very much.
A very excellent presentation, Sarath Chandra. Most of us will do a lot of mistakes during donning and doffing. And you're very, very well enlightened all these things. And any questions from our audience?
I'm thinking, Dr. Varaprasad. So during surgeries, we cannot use high-speed drills and all, craniotomes. What is the alternative you are suggesting during craniotomies?
Yes. So that's an excellent question. So what we do is, we always enter the OTs 20 minutes after the intubation, wearing goggles and wearing triple masks. And then we do the craniotomy. And then while doing the drilling, what we advise is we take a steady drip, which is large, and we cover it on the head, make a hole, and then do the drill using through the plastic transparent steady drip. So that way one is able to do a craniotomy and most of the aerosol is within the steady drip. So you create a kind of an air pocket and use the drill inside it. This is definitely a bit uncomfortable, but this is the best thing we can do. And now there are some companies like Surgiware which are coming up with umbrellas. You can use this umbrella and then do a drill. And once the drilling is done, it is important for you to wait for at least 10 minutes. Problem is it takes some time with all these protocols. and once at least 15 to 10 to 15 minutes, and once the aerosol kind of settles down inside the compartment, you can remove the sterile drape and then change your gloves. And when you bring in the microscope, you could remove your goggles, because that is when you don't have any other aerosol exposure. But while the drilling is being done, you should wear a goggles, and it should be done within a compartment.
Another thing is a transpenoidal route, we cannot do pituitaries.
Transphenodal, there are places where people are still doing transphenodal, but I have given up doing transphenodal because I think it's too risky. So I do most of the pituitaries using an eyebrow incision. It's a minimally. Similarly, one can also do a mini T-renal approach. It is not such invasive at all, and all our teachers have been doing transcranial approaches.
Yes. Our teachers also. We have to adapt to new COVID circumstances.
Absolutely.
So we have to change our procedures also.
I have seen some centers where they do transphenodal using an umbrella. Again, they use a plastic drape,
Yes.
and then they put the endoscope through that and do it. But it's all inconvenient. It's better to.
Right. Thank you, Sarath.
After I'm Dr. Sivaram Krishna. Hello.
Okay, Sivaram Krishna, go ahead quickly.
After running a COVID hospital, converted to a normal hospital, particularly ICU operation theaters, what are the precautions and how much period we need to wait to convert into normal structures?
There is no need to wait for any period of time, provided the entire hospital, everything is completely cleaned and sanitized. The most important thing is doing modifications of the air conditioners. So one should speak, and obviously the HEPA filters have to be changed. There is no need to clean the air ducts, and one has to speak to the engineers to ensure that the air conditioning systems are good. Once a COVID hospital, there is practically no time. I mean, maybe the usual sterilizing procedures what you take when you sterilize an ICU or a ward or OT. You follow the regular protocols, and you may have to discuss with your engineering for the air conditioners. So
What
for
about the
instance, if the hospital has split air conditioners and they have been using it in public areas, so that is a problem. Then the split air conditioners, the filters may have to be changed. But if it's a central air conditioners with high flow, with a fresh air circulation, then at best, the maximum you have to do is just change the HEPA filters, nothing more than that.
What about the ventilators?
Ventilators again can be ventilators can again be sanitized properly. There are protocols which have been described on how to sterilize or sanitize the protocol, and these are all well established. And once they are done, they could be used for normal patients also. So there is enough literature available on this, enough data available in the literature.
Thank you, Sarath Chandra. Excellent presentation. All practical.
Thank you very much for this opportunity again.
Thank you, sir. And